So for this presentation, I'm going to talk about a MI, or also called a myocardial infarction. We're going to talk about some things that contribute to it. We're going to talk about assessing people for signs and symptoms of an MI. We're going to talk about how we actually diagnose it, and then what do we do for it. What I want you to realize is that cardiovascular disease is the #1 cause of death in the United States. Just to give you some numbers, that's about 1 death every 25 seconds from cardiovascular disease. One of the main things that contribute to coronary vascular disease is coronary artery disease. This is also referred to as CAD. In CAD, you have two things going on. You have arteriosclerosis, which that's actually a thickening of the vessels. So the vessels become very thick. They're not able to contract as well. And then you have atherosclerosis. And what that is, that's just an abnormal accumulation of fatty substances within those vessels. So the two things that are going on is, one, the vessels are getting accumulated with abnormal fat or plaque throughout the vessel. And then the other thing is the walls of the vessel are actually becoming very thick, and so they're not as mobile and they cannot contract like they need to. Now, when you talk about coronary artery disease, there are some risk factors. Realize that we have modifiable risk factors and we have non-modifiable risk factors. So in nursing, what we primarily focus on is we focus on your modifiable risk factors. These are the ones that we can change. We know that nutrition is one of the most important parts of prevention and maintenance. So for people that have CAD, coronary artery disease, they often have very elevated lipids, including cholesterol and triglycerides. Therefore, our goal is to try and reduce those numbers in these people, because what you need to realize is if someone has an elevated total cholesterol, it can actually increase their risk of having a MI. So that's why we focus on, let's get control of this cholesterol, and we do that through nutrition. The first thing we focus on, again, like I said, is nutrition. We want them to have a heart-healthy diet, a diet that's low in saturated fats, low in cholesterol. The other thing we want to look at is we want to look at what are some risk factors. Do they smoke? The reason we focus so much on smoking and wanting them to stop smoking is because when they smoke, it is the actual nicotine in the smoking, or even in the vaping, or everything else they're doing now. It's the nicotine is the issue. Because remember that nicotine, it's a vasoconstrictor, and it also reduces the blood flow. And so what that does, it leads to an increase in the vessel wall thickness. Remember, with smoking, that also applies to secondhand smoke. So the other thing I always like to talk about is there's no such thing as light versus ultralight when you're talking about nicotine, as far as it doesn't reduce their risk. So we want to look at educating them on stopping smoking, because all cigarettes are equal in the damage that they cause. The other thing we look at is we look at obesity. Well, obesity and physical inactivity, they tend to go hand in hand. So what that means is if we focus on increasing their activity level, then we're going to reduce their likelihood of becoming obese. The only thing I'm going to say here is you need to educate to your patient's ability and their, because sometimes we educate so much and we can be very disheartening when we tell someone they need to walk for 20 to 45 minutes a day. If you have a person who does not have a very active lifestyle and doesn't get out and walk, they're kind of like, well, that's a lot to start off with. So you want to start in small measurements or small intervals, and then gradually increase that. So those are the things we really want to focus on when we're looking at your modifiable risk factors. So that's what you're going to educate on. Now, other things you need to be aware of, some of your labs, we need to know all your labs for cholesterol, so you'd be able to identify if someone had abnormal cholesterols. So your labs are talked about in Chapter 38. You have a chart, I think it's 38-1. And then also 33-2 is another chart that you want to look at for labs. So look at those labs. Also look at that chart on prevention of CAD, because you want to make sure that you are aware of the numbers because you're going to need that when you're doing your assessing. So modifiable, remember, those are the ones that we can change. But when you talk about non-modifiable, these are things that we can't change, but we do realize that these risk factors make you more likely to develop CAD. One is we know there is a genetic link with CAD, so if you have a strong family history of CAD, then you're more prone to develop that. Also, age. We know with CAD it increases as you age, and so our older individuals are more likely to develop CAD versus the younger individuals. Also, gender does play a role in it. Men have a higher risk than women of developing CAD until women reach about 80, and then at that point they're both the same as far as their risk for developing CAD. And then also ethnic backgrounds. CAD is more common in African Americans and Hispanics. So the other thing I'd like to talk to you about or bring to your attention is angina. When you talk about angina, remember angina is caused by a temporary imbalance between the coronary artery's ability to supply O2 and the cardiac muscle's demand for O2. So that's what's going on. The coronary artery is unable to supply the oxygen that is needed by the cardiac muscles. And so that's what causes the pain that's associated with angina. You have two types of angina. You have stable angina and you have unstable angina. Now, stable angina, it's caused by moderate to prolonged exertion. And the thing with stable angina, it follows a very familiar pattern. What I mean by that is the frequency, the duration, and the intensity of symptoms, it's going to remain the same. And usually rest and or nitroglycerin relieves stable angina. So unstable angina, we have different types. We have new onset angina, we have variant, we have pre-infarction. So all of these types of angina are considered unstable. So if you want to look at the definition for unstable angina, it is actually chest pain or discomfort that lasts longer than 15 minutes. It can occur at any time. And it actually severely limits that person's activity. The other thing about stable angina, nitroglycerin typically does not relieve it. So that's the main differences between your stable versus your unstable. The different types that I provided for you here, new onset, this typically is going to occur after the person has started some type of activity, okay, or they've exerted themselves in some form or fashion. Now variant, this is actually caused by coronary artery spasms, and variant chest pain, it typically occurs at rest. And the neat thing about the variant angina, if you hook them up to a EKG at that time, or you do an EKG on them, I should say, what you can see, you can actually see some ST elevation during the attack. Now when we talk about pre-infarction, this is chest pain that occurs days to weeks that actually precede an MI. So you need to make sure that you're aware of the different types of chest pain. They're provided for you in Chapter 33. So please make sure and take some time and review those, because as a healthcare provider, you're going to need to know the different types of chest pain. So when they're describing the symptoms, you know if it's something that's typical, that's to be expected, or if it's something that you need to react to very rapidly. So the reason that I group angina and MI together, they are two different things, but here's the thing, guys. They present with the same signs and symptoms, okay? You can't just look at someone and tell, is this angina or is this person actually having an acute MI? You can't, because they present the same. And so when I talk about your signs and symptoms, I want you to realize that your signs and symptoms are the same. So everybody that comes into the emergency room with the complaint of chest pain, you need to treat them like they are having an acute MI until you rule out they're not, because you cannot tell the difference between the two. And what you need to remember is that the rapid assessment of chest pain and any of those other symptoms that are presented here, they are crucial, because what you need to realize is time is muscle. the longer it takes for them to get treatment and to get blood restored to the heart, the more damage that is being done, the more muscle that is being destroyed. So be aware of this. In chapter 38, these signs and symptoms are presented. So look at that material, read that chapter. But some of the things that you're going to see in your patients is they often complain about chest pain. Okay, but it's a chest pain. Sometimes they describe it as a really like a belt around their chest that's squeezing, or they feel like an elephant sitting on their chest. It's chest pain / pressure. They also will sometimes complain of not feeling well. They feel very weak. They're having periods of dizziness, nausea, and vomiting. They're getting really anxious. Sometimes people just come in and they just present with just jaw pain and a choking sensation, or they have tingling and pain that's radiating down the arms. So as you can see by just looking at these signs and symptoms, a patient can present with multiple ones, or guys, they could just present with one. But again, if someone comes in and they're presenting with signs of an acute MI, you take them seriously and you treat them as if they're having an acute MI until you rule that out. So what you need to realize is that, remember, if it's stable angina, then that is ischemic pain, and that is usually going to be relieved when you meet those O2 requirements. So that's one reason why they come into the ER and they complain of chest pain, and we always put them on oxygen, is because we know they don't have enough circulating, and so we're always on the lookout for that. The other thing I like to talk to you about is I like to talk to you about the difference between men and women. Oftentimes men and women present differently. These signs and symptoms you see right here, these typically will present in men, but women, remember, women present differently. We call it atypical chest pain. So oftentimes what they'll present with is indigestion. They'll complain about pain between their shoulder blades, also an aching jaw. So the sad thing about this is oftentimes women are misdiagnosed when they come in. They might actually be having an acute MI, but they're misdiagnosed with things such as stress or panic or anxiety disorder, GERD, reflux. Sometimes they even attribute these signs and symptoms to menopause. So that being said, again, when women present with these, you need to take them just as seriously as a man that presents with these signs and symptoms, because we don't know. So I told you they present with the same signs and symptoms. Now, let's talk about how we tell the difference. Okay. Basically, there's three main things we look at. We have lots of things we look at, but there's three main ones. The first thing we look at is we look at patient history. So what I mean by that is this is where you play the detective and you're going to ask a lot of questions. One thing you're going to ask is, have you ever had chest pain like this before? If they do, then you need to do a compare-contrast, meaning, is this chest pain like the chest pain you had in the past? Is it different? How? Also, you want to ask about the location, the intensity, the duration, the precipitating or relieving factors. What makes this worse? What makes it better? Is this the first time this has ever happened? Look at their history as far as are they at risk? Do they have any of those risk factors I presented you earlier with CAD? Because if they do, remember that CAD can contribute to an MI. So you're going to be looking at all of these history things that you, when you do your questioning, okay? Have them rate the pain on a scale of 0 to 10. 0 being no pain, 10 being the worst pain ever. And then another thing you're going to look at is you're going to look at your EKG, okay? But here's the thing, guys, with an EKG. Someone can have a completely normal EKG and they can still be having an MI. And so that's why we don't just take, or I should say, we don't just give someone the diagnosis of an MI based on a positive EKG or a negative EKG. We don't take any one of these three things by themselves. We look at the whole picture. And there's other tests that we might do to give us a better overview of what was going on with this patient. But these are the things, when we look at that EKG, what we're looking for any type of ischemic changes. So ischemic changes that you could typically see, you can see ST depression, you can see T wave inversion, or you can actually see both of them. Because remember, when you're talking about MIs, you have something we call a STEMI and a non-STEMI. So a STEMI MI, that means that they do have ST elevation. And a non-STEMI, that means they have non-ST segment elevation. So realize that EKG, we're looking at different things. And then the third thing we look at is we really want to look at their labs. Okay, that is something that is very important that we look at. The thing you have to realize is when you're looking at labs, our most specific is troponin. Okay, and so realize that is going to be your most sensitive marker for someone having an MI. You're going to be looking at the troponins, because remember, those troponins are only in cardiac muscle. The problem with troponins is it takes a while to peak, guys. A lot of times they don't peak until 12 hours out. So we have to do some other things, and we look at some different things. And so while we look at troponins, we also look at other cardiac enzymes. We look at a CK, a CKMB, and that kind of helps us along. A lot of times we call all that combined, we call it cardiac enzymes. And the reason that is because those specific things release enzymes. And the thing you need to realize is when you do cardiac enzymes, or when you do troponins, CKMB, things of those nature, you don't make a diagnosis based off just one, because one doesn't help us see the overall clinical picture. Because as I told you, that your troponins typically don't peak for up to 12 hours. They do start to increase sometimes around the 8-hour mark. Okay, so it's 8 hours from the onset of the chest pain. And so we need something that tells us that what's going on a little bit sooner. So other things that we will look at, we will also look at your PT and your PTT. Okay. Other things we will look at electrolytes. We want to know we'll do a BMP, and we'll look at what's your potassium, what's your magnesium, what are your electrolytes, because some of those can cause chest pain if they're outside the normal range. So these are all things that we want to look at when we talk about labs. So remember, in a normal individual, their troponin level, it should be 0. You should not see troponins in healthy people. So when you see them, or when you see them start to be elevated, that should be cause for concern with you. So additional things we can do that kind of aid us in diagnosing cardiac injury, or looking at other things related to cardiac. We'll do an echocardiogram. So essentially what an echo does is the echo allows us to look at the heart, and what we're looking for is it allows us to look at the shape of the heart, the valves of the heart, to see if there's any type of issues going on with that. It allows us to get a really good picture of the overall heart. The other thing we like to do is we can do something called a TEE. So this is the TEE. Okay, so that stands for transesophageal echocardiograph. I know that's a lot, so we just usually refer to it as a TEE. So a TEE and an echo, they essentially are the same thing. The main difference is your TEE. It allows us to look at the posterior view of the heart, where the EKG typically is just the front view of the heart. The other thing you have to realize with the echo is that sometimes it's hard to get a very accurate view of the heart if you have an individual that has very large breasts, or they're very obese. And so if that is the case, then sometimes we'll do the TEE, because remember, that's where they take the little visualization tool and they numb the throat and they put it down that way and look. And so sometimes we get a little bit more accurate picture there. We can also do something called stress tests. I'm sure most of y'all are familiar with stress tests. You've either cared for a patient that's had a stress test, or you know someone that's had a stress test. Now there's multiple ways of, or I should say there is multiple ways of doing stress tests. We can do a thallium, a graded, or a prasantine. So thallium and prasantine, those are medications that we inject into an IV site that's in a vein to mimic them walking. So what it does is it gets the heart rate up, because in a stress test, what we are doing for is we want to actually assess the heart's response to an increased workload. The other thing the stress test does, it helps us determine the functional it helps us determine the functional capability of the heart. Also, what we like to do is when we do a stress test, we can actually screen for asymptomatic CAD. So if you're going to do a stress test on some people, our favorite, or the one that usually is that we do most often, is the graded. That's the one you're probably most familiar with. It's where they get on the treadmill and they increase the speed and they increase the incline of the treadmill to get their heart within whatever range that the physician has decided they want that range in, to see if the heart or see how the heart responds to the increased workload. Okay, that's probably the one you're most familiar with. Again, if they have mobility issues and they cannot get on the treadmill, what we'll do, we'll give them thallium or we give them persantine. There's no difference between them as far as is one better than the other. Typically what happens is the hospital just gets whatever one is most readily available to them. So that's kind of when you do the medication-induced stress test. Same things you need to realize. If someone is going for a stress test, you do not want to give them anything that is going to lower their heart rate or prevent their heart rate from increasing, because remember, the whole goal of a stress test is to stress the heart out. So that being said, you don't want to give them beta blockers. You don't want to give them calcium channel blockers. You don't want to give them their nitrates before they go down. Okay, because think about it. Remember, the whole purpose of a beta blocker and calcium channel blockers and a lot of your nitrates or your DIG, their purpose is to decrease the heart rate. Okay, either through decreasing the strength of the contraction or vasodilating. But all in all, their overall job is to decrease that heart rate. So the problem is, if I'm giving someone a medication that's going to decrease their heart rate or keep their heart rate below what I want it to get at, then I don't want to get it, because remember, my goal in a stress test is to increase their heart rate. Okay? So please realize, if someone's going for a stress test, to hold those medications until they come back. Okay? Now, you can go ahead and give blood pressure medicines that are not going to affect the heart rate, but the ones that you know are going to affect that heart rate, you want to hold until after that procedure, because if you give them those medications, then the stress test will be invalid. Either it will not, well, one, it won't be accurate, but two, they probably will not be able to do it because they cannot get the heart rate up where it needs to be. So please remember that prior to going for a stress test. The other thing you want to realize, if someone has positive cardiac isos, meaning they have a positive troponin level, we don't want them to have a stress test. And the reason that is remember, if someone has positive troponins, then we have already established that they have some type of cardiac damage, and we don't want to further stress their heart by having them do a stress test. So realize that that is contraindicated. If someone has positive cardiac troponins, they're not going to get a stress test. Another thing that they can do that I always like to talk about is a cardiac catheterization. I hope by this point in nursing school that y'all had an opportunity to see a cardiac catheterization. If not, I hope before you get out of the program that you're able to see it, because it is really neat to watch. So a cardiac catheterization, you need to realize it is the most accurate test in diagnosing coronary artery disease or any type of blockages that are occurring in the left or the right side of the heart, or even the coronary arteries. So it's a pretty cool test that they do. The things you need to realize is we do have some pre-op and some post-op things and some things we need to just watch for that we're going to talk about. So again, it is a minimally invasive test, and it offers clear, accurate information about the heart's coronary arteries. That being said, it is an invasive procedure, so you have to get a permit. Now, when you're getting a permit, typically what we do is we get 3 permits. We get one for the actual, we call it the intervention, okay? We get one for the cardiac catheterization, and we get 1 for blood. Okay, so we get the patient to sign all 3 of those. And here's the reason why. When we do a cardiac catheterization, we are going into a major vessel. Okay, we're going in, and we're going in through an artery. So the potential for bleeding is very high. And so in the event that they do bleed and we are unable to stop it, we want to be able to give them blood products ASAP, not have to wait. So that's where we always go ahead and get the blood permit. The other thing we want to do is we get the permit for the actual cardiac catheterization, because here's what you got to realize. The cardiac catheterization is a diagnostic, or I should say, is a diagnostic procedure. It is just a procedure. It is just letting us go in and look. That is all it is doing. Okay, that's what that consent is for. If the cardiologist gets in there and he sees blockages and he needs to fix those blockages, well, then we need to get an intervention form signed. And so we always get that signed beforehand, because remember, to do this cardiac catheterization, we sedate the patients, and you have to get all your permits signed before you sedate them. So those are the 3 consents that we get signed prior to a patient going for a cardiac catheterization. As I told you, it gives us a clear, reliable information about the heart. So the thing you have to realize is your patient has to be aware of the risk factors. So some risk factors involved with the cardiac catheterization, bleeding is one, especially around the insertion site. We used to always use the femoral artery. However, we've kind of gotten away from that in practice, even though it is still used sometimes. But we like the brachials a lot better, just because of, 1 is visibility, and 2 is its infection rate. Okay, we have a lower infection rate with the brachial versus any of the other ones. But however, realize it can be any type of, it could be any artery, any major artery. So just realize that. Okay. Other things that can happen is they could have a blood clot. We could actually perforate the blood vessel. They could have an MI. They could have a stroke. They could have an air embolism. They also could develop abnormal rhythms, because we are actually taking a coated stylet and going into the heart. The heart really doesn't like to be messed with. And so when you start messing with it, then what it tends to do, it starts having abnormal rhythms. Or the patient could actually have an allergic reaction to the dye that's used during this procedure. And so that's one reason you always ask about, do they have any type of iodine allergy? Okay, because the dye that we use, it's an iodine based, and so if someone has an allergy to iodine, shellfish, contrast dye, then they're going to have issues. We don't want them to have allergic reaction. So these are all the things that they need to be aware of, the risk factors. So really the benefits have to greatly outweigh the risk prior to doing a cardiac catheterization. Other things we want to make sure and do, while it is minimally invasive, it still is an invasive procedure, and they do have a higher than normal percentage, or likelihood, I should say, for bleeding. So we want to get a PT and a PTT, and we also want to see what their CBC is. Okay. Other things we want to do is we want to get a BUN and creatinine level. Remember how I told you earlier that the dye they use is iodine based? The other problem is, I should say, the dye they use is it's nephrotoxic. So it is toxic to the kidneys. So if you look at someone's BUN and creatinine and it's higher than expected, what you need to do is you need to call the cath lab, because what that tells you is they're not perfusing, their kidneys don't perfuse like they should, and so that dye that's nephrotoxic, and an individual that has impaired kidney function, it's going to stay in the kidneys longer, and so the patient has a higher likelihood of developing acute kidney failure. It's going to damage and kill off the kidneys, and you don't want that to happen. So what happens is, if somebody does have impaired kidney functions, typically the cardiologist will either consult a specialist, they will start Mucomyst, and if you look up Mucomyst in the drug guide, it will tell you it is a bronchodilator, and that is true. But you know how sometimes we use medications off-label for different uses? Well, what we found is that Mucomyst It also increases renal perfusion, and it just adds additional protection to the kidneys. So a lot of times what we do is if someone has impaired kidney functions, we like to put them on that Mucomist 12 hours prior to the cardiac catheterization and up to 24 hours following the cardiac catheterization. So the whole time that kidney could potentially, or I should say the dye is in the kidney, that Mucomist is helping protect it. Other things we do, we're going to start some fluids on them, okay? We're going to start fluids in hope of making their kidneys work a little bit better. We need to continue the fluids. Again, you follow your doctor's orders, but typically it's up to 1 to 2 liters of fluid after, or it even can be fluids for 24 hours, but your healthcare provider will decide that, but realize that they need the fluids to make sure that they push out all of the dye that's in their kidneys. So you definitely want to notify a doctor of elevated BUN and creatinine. Also, if they have an iodine allergy. Other things you want to look for before they go down is you want to make sure and check the peripheral pulses and your lungs before they leave. You check your peripheral pulses because you need a baseline for when they come back. So if I check my peripheral pulses and they're +2, and when they come back from the procedure, I check the same peripheral pulse and it's a +1, then I know there's an issue somewhere. I need to be calling the healthcare doctor and letting them know that, look, they were a +2 before they went back, but now they're a +1. The other thing is look at the color of your extremities and look at the cap refill. Do they look like they have good perfusion? Feel the temp of them, okay? Because guys, remember that is how we check perfusion is we look at the color and the cap refill and things like that. And if they're abnormal or they're not what they were when they went down, then you know there's something going on there, some type of occlusion when they went in there, and they need to be notified so they can handle that ASAP. The reason I tell you to check their lungs, especially in your older population, is because when we do a cardiac catheterization, we do give them lots of fluid during the procedure. And so what happens is sometimes your patients become overloaded. So if you have a baseline of what their lungs were like before they even went down, and they come back and you listen and they start sounding really crackly, what that tells you is, oh, wait a minute, this person, we got some extra fluid we need to get out. Now remember, you're not going to stop your fluids, okay? Because remember, you got to get those fluids to help with the kidneys and getting that dye out. But what you're going to do is you might just slow it down a little bit, go call the healthcare provider and let them know. Typically what they're going to give you is they're going to give you some order for some type of diuretic to get rid of some of that excess fluid. So that's what you would anticipate. So you need a baseline so when they come back, you know what's going on. You also want to hold all non-necessary meds. So let's talk about necessary meds. Blood pressure medicine, that's necessary. Cardiac medication, that is necessary. The protonics is not necessary. The vitamins. So what I mean by necessary is what's going to keep them maintaining at their optimal level. Okay? You want to hold everything else and you want to give that when they come back. And the reason you keep them NPO is because there is the potential, as I told you, for a perforation of the vessel. And guys, the only way to fix that after we have gone in there is they have to have emergency open heart surgery. And if they have a belly full of pills and other things, they're at an increased risk for aspiration, and you don't want that to happen. So that's truly why we have them NPO prior to this procedure. So that's everything we do pre-op. Now, I have this link posted for y'all. Well, you see it on your handouts too. You need to go and watch this cardiac procedure. It's not really long, but it just kind of reiterates everything I just told you about, and it shows you, it's really neat. It shows you how they actually thread the catheter through. So please take a few minutes and watch this video or follow the link that is on the handouts so you can see what I'm talking about when I talk about a cardiac catheterization. When they come back post-op, there's some things you need to make sure and do. This person is going to be on frequent vital signs. You want to follow your hospital policy for frequent vital signs, but also realize you're going to be checking the site every time you check the vital signs, because remember, they did go in through a major artery, so they do have an increased risk for bleeding. The other thing you want to do currently, the head of bed is no greater than 30 degrees. And realize the patient's going to be on bed rest depending on two things. One, what type of closure device they use, and two, were there any, what kind of interventions did they do? Okay, and so your post-op orders will tell you that, but realize they will be on bed rest, and that if they went in through a leg or an arm, that arm and leg have to stay straight for that prescribed amount of time. Other things you want to make sure when you're looking at your site, things you're looking for any type of bleeding, hematoma formation. You're also looking for any complaints of back pain, or really they complain about back pain, but they also complain about feeling like they have to have a bowel movement, because sometimes that is a sign of retroperitoneal bleeding. So make sure and check that out. Also, remember, it's very important that you make sure that you follow your orders for the fluids. You don't want to just DC fluids. You don't want to DC the mucomist. Your physician will order that for a prescribed amount of time, so you need to make sure and follow that. Look at the color of your legs. If you had a nice pretty pink leg before you went down, and they came back from this procedure and that has turned a blue or a gray kind of color, we call it dusky, then you know what, that tells you there's something going on there. That perfusion is not as it should be, and you better be calling the doctor, because you don't have that long to fix it, because remember, time equals muscle. If for some reason, let's say you do bleed, or your patient does bleed out, remember, it is a major artery, so you have got to put pressure on it. What you would do is you would go a ½ inch above the puncture site, and you're going to apply firm, steady pressure. You're going to be there for a while, guys. You're going to be there for about 15 minutes, okay? And so while you're putting pressure on, you need to call for additional assistance. Then what you will do after that 15 minutes, you will look at that site to see if there's still some bleeding going on. If there's not, if you have stopped the bleeding, then typically what we do is we get a sandbag, put the sandbag on the site, and their bed rest starts over from that point in time. However, if they're still actively bleeding, then you're going to hold pressure again, firm pressure again, and then what happens at that point in time, typically you will transfer them to more of a cardiac intensive care unit, just for closer monitoring, because they can use things such as a FEM stop that you can't really use on just a med surg floor, because it requires very close monitoring. So that's what you would anticipate doing, but your bottom line is you got to stop that bleeding, and so you have to hold pressure. So these are just all some of the procedures that we do to try and diagnose someone, to see what's going on with the heart. So let's say that you went through everything, they came in the ER, they were having chest pain, you've ruled out an MI, and they just have angina, okay? They have just been diagnosed with stable angina. So then what you do is you gear your treatment around medication management. That is our goal. Your drugs are listed in chapter 38, so please make sure you look at your drugs. But some things you're going to see, nitrates. The reason we like nitrates, guys, is because it increases collateral blood flow. It dilates the coronary arteries, and it also it decreases the O2 demand. The thing you got to be careful about when you give nitrates is you don't want to administer it to a patient who is taking meds for sexual dysfunction, okay? So beta blockers. Beta blockers, these medications right here, I always like to say they make the heart work smarter, not harder, because what it does is it slows the heart rate, and it reduces the force of the contraction, okay? But again, remember, beta blockers, you better be careful, because it can lower that heart rate, so you better check the heart rate before you give a beta blocker. Calcium channel blockers, they are the same principle. Calcium channel blockers, they enhance vasodilation, and they also enhance myocardial perfusion. So that is a lot of times why we will give the calcium channel blockers. We will give, if needed, antiplatelet and anticoagulants, and this right here just prevents the likelihood of a thrombus from developing. So you will see these often used. If they have angina and it's related to coronary artery disease, meaning they have excess plaque in their vessels, or their vessels have lost their ability to contract appropriately, we can do some revascularization procedures. And those revascularization procedures, I'm going to talk to you about those in the next presentation. So just hold on to those, because I'm going to come back to those. So let's say that we looked at their EKG, we looked at their labs, and their patient history. And let's say we found out that they were having an acute MI. Okay, so we have different types of MIs. We have one called, and I told you earlier, we have a ST elevated MI, we have a non-ST elevated MI, and then we have something we call unstable angina. These three things, they are all listed, or they are all grouped under an acute coronary syndrome. Okay, so please be aware of that in your terminology, because sometimes when you're looking at your H&Ps, it will tell you they had an acute coronary syndrome, and that's what it means. These types of MIs are associated with a sudden rupture of plaque inside the coronary artery. So what you have to realize is your whole goal in someone who's having an acute coronary syndrome is you want to increase the circulating oxygen to stop the progression of tissue death. That's your whole goal. So when you're thinking about an MI, some things you need to look at. We have these different zones. So you have the zone of infarction, okay? This is this right here. This is where the tissue the tissue's died, okay? The tissue has died here. But then these other zones, this is the zone of hypoxic injury, and this is the zone of ischemia. So remember, once tissue is dead, we really can't do anything for it, okay? We just realize that area is always going to be weaker. But remember, if an area is just hypoxic or it's just ischemic, then if we get oxygen to it, then those zones will be very small. We're able to save those cells. And so that's our main focus. That's why we want to increase the circulating O2, because we don't want this zone of infarction to get any bigger. So that is why we have such a big push for it. Let's do reperfusion. That's why now that when someone comes in with an MI or anything of that nature, you have the overhead pages, and that the Centers for Medicare and Medicaid have determined that you have to be within the cath lab and ready to be stented within such a very specific amount of time, because we know that the sooner the person gets that oxygen perfusion going, the better the patient's outcomes are going to be. So the actual zone of infarction, this thing right here, it depends on three things. Okay, one is collateral circulation. So if the person has collateral circulation, then that zone of infarction will not be as large. Here's the thing about collateral circulation, though. It is usually more developed in older adults, and that's why your older adults have a higher survival rate. The second thing that determines how large your zone of infarction is your anaerobic metabolism, meaning how well do those cells function without oxygen. And then the third thing is the actual workload demands on the myocardium. So those three things together determine how big this zone of infarction is going to be. So when someone comes in and we have ruled that they are having a MI, what we're going to do is, of course, we're going to give them oxygen, because we know they don't have enough circulating oxygen to support cardiac demand. So that's one of the first things we're going to do. Another thing we're going to do when you look at medications, we like to give them an aspirin, okay? The reason we like to give them the aspirin is because it is an antiplatelet, and it actually inhibits the platelet aggregation, and it inhibits vasoconstriction. The reason we want to do that is, therefore, it's going to reduce the likelihood of a thrombus. So that's why we always like to get them to chew up that 325 milligram aspirin, okay? It's because we want that antiplatelet drug to start working, and we do not want them to develop a thrombus. So if someone comes in and they are having a acute coronary syndrome, we like to use thrombolytic agents. You're probably most familiar with things they're called Retivase is one that you might be familiar with. TPA. So remember TPA, that stands for tissue plasminogen activator. Okay. So we will give thrombolytic agents, and those are the names of the thrombolytic agents that we like to use. Here's the thing about thrombolytic agents. They are most effective when they're delivered within the first 6 hours. What they do, a thrombolytic agent, it actually dissolves the thrombus that's in the coronary arteries, and it restores the myocardial blood flow. And so this is really, really good. However, there are some contraindications for using TPA. Some of them are if someone's had recent abdominal surgery, you wouldn't want to use that, okay? Or you wouldn't want to use this one. Also, you have some other contraindications, such as if they've had a recent surgery or if they've had a hemorrhagic stroke, okay? Because the bad thing about the TPA is it's not selective for just thrombus in the coronary arteries. It dissolves the clots throughout the body. Okay, so that's where you come into some issues. These contraindications, they are listed in your book in chapter 38. It's 38-2, so you want to make sure and take a look at that. We also will use heparin. We like to use heparin because it facilitates the thrombolytic treatments that we've used, and it also, especially after we've done any type of reperfusion procedure, it decreases the chance of reocclusion. Okay, so that is what we do with heparin. And then again, beta blockers, as I've already told you, beta blockers, it slows the heart rate, but the reason we're using it here is because it decreases the force of the contraction, and it actually decreases the size of an infarction. And another thing we found in a study is that if you give someone beta blockers while they are having an MI, it's going to decrease the likelihood of them developing a ventricular dysrhythmia. And it also it decreases the mortality rate by 23%. So if they meet criteria to get a beta blocker, you definitely want to get that beta blocker in. I've talked to you about nitrates, guys, but here's the thing about nitrates. It increases collateral blood flow. Okay, it redistributes blood flow toward the heart, and it dilates those coronary arteries. Okay, you got to watch your blood pressure. Anything that you give that is going to vasodilate someone, it has the potential for dropping their blood pressure. So you have to watch their blood pressure when you give this. The other thing is, as I've told you earlier, you need to make sure they are not on any type of sexual dysfunction medication, ED medication. And the reason that is because both of those medications, they cause the muscles that control the size of the blood pressure, and so it will lead to, if you give nitrates and ED medications, it will lead to a major drop in your blood pressure. So please make sure not to give it. Other things that you'll see, ACE inhibitors, we like to give these within 48 hours, and the reason we like to give these is it actually prevents ventricular remodeling. So remodeling is just another fancy way of saying it prevents any changes in the size, the shape, or the function of the heart. Also, these ACE inhibitors, they are going to help prevent the development of heart failure from occurring. Again, calcium channel blockers, they enhance the vasodilation, and they also enhance myocardial perfusion. Morphine is our drug of choice in someone who's having an MI. And the reason we like to use morphine for pain control, it decreases the myocardial O2 demand. And if it's cardiac in nature, typically this works very well for it. The other thing it does is it helps relax all the smooth muscles. So you'll see these a lot. Remember, one of the signs and symptoms of an MI is extreme anxiety. So if someone's having anxiety, then we can give them some anti-anxiety medications. And so a lot of times you will see us do that. I always like to talk about some complications that can occur from MI. Now, I just briefly touch on these because you will get most of this material in 203. So I really just need you to kind of be aware that there can be complications that occur because someone has had an MI, and you kind of need to be on the lookout for these. One is a cardiac tamponade. So when you talk about a cardiac tamponade, essentially this is a compression of the heart. It occurs when you have blood or some other fluid. It builds up in the space between the heart muscle and the actual pericardium. Remember the pericardium, that's the outer layer of the heart. And so lots of things can cause this. Most of the time what it is the person has had I think it's, let's see right here. I can get to it, right. They have had some type of rupture. Either a ventricular rupture or a myocardial rupture. Those ruptures, typically they occur on the site that the MI did, because remember that zone of infarction? That zone of infarction is an area of dead, weakened muscle, and so a lot of times that does end up rupturing. So when that occurs, you can actually have the accumulation of blood in that area. So if someone develops this, what you will see something called Beck's triad. So when you look at Beck's triad, you have three things going on. One, you have distended neck veins, and that's just because the blood is backing up. You also have distant heart sounds, and the reason you have distant heart sounds is because remember that blood is between the heart muscle and the pericardium, and so you have more that you have to listen through to hear the heart sounds, and then your person will also become hypertensive. Okay, so here's the thing. The only thing we can do for this complication is we have to drain that fluid. Have to. That is the only thing we can do to treat that. Now, I talked to you a little bit about ruptures. The thing about a rupture, remember that it's an actual laceration or a tearing in the wall of the heart, and typically it's wherever the MI occurred, wherever the damage occurred from the person having the MI. This usually occurs within 3 to 5 days following. So a lot of times the people are getting ready to go home, or they already are at home when this myocardial rupture occurs. Remember, it's a rupture or a tearing, okay, in the wall of the heart, and so that is why the survival from this is very, very rare, because typically what happens is your patients tend to bleed out. When this rupture occurs, your patient will start having a very acute onset of shortness of breath, chest pain. They will have unexplained vomiting. They'll become very pale, very sweaty. But again, unfortunately, the prognosis for someone who's had a myocardial rupture is very dismal. Cardiogenic shock. The reason I like to talk about cardiogenic shock is because you will come into contact with it a lot. It's about 20% of people who have had acute MI, they develop cardiogenic shock. So in someone who has cardiogenic shock, your signs and symptoms typically are they have a rapid onset of shortness of breath. They have a very rapid, irregular heart rate. They become very hypotensive. They become very confused, pale, sweaty. They'll have very cold hands and very cold feet. They'll lose consciousness. So what happens here is the reason they're having those signs and symptoms, guys, is because the heart, for whatever reason, is unable to effectively pump blood throughout the body to meet the actual demands of the tissues and the organs. So that's why you have those signs and symptoms. So if someone is going into cardiogenic shock, that is a medical emergency. So typically what we do is we are going to insert an intra-aortic balloon pump. So what this is actually a balloon pump that we insert into the main artery of the heart, because remember, guys, their heart is not pumping effectively. So we have to have something to take over to pump until we can fix whatever the problem is. So this balloon actually goes into the main artery of the heart. And what it does, it inflates and deflates, and it mimics the pumping action of the heart. And that way it helps the blood flow as it should. Now, please realize this is just a temporary fix. This is not a permanent fix. What we have to do is we have to go in and I say we, a healthcare provider, a cardiologist has to go in and determine what is causing this blockage. Typically where it is, it's the area that they have either put a previous stent in, or the vessel that that was damaged from the MI has reoccluded again. And so they have to go back in there and they have to open it up. So a ventricular rupture, realize that a ventricular rupture, as I've already talked to you about earlier, this occurs in an area in the ventricle. Usually it is where the MI, the zone of infarction of the MI was. And what happens is it prevents the ventricle from filling and pumping the blood that's needed to the body. Okay. And then when you talk about an aneurysm, remember an aneurysm is an outward swelling or a ballooning in the wall of the ventricle wherever the MI occurred. So the problem with an aneurysm in your heart is it increases the workload of the heart. It also makes for a very ineffective muscle contraction, and it leads to cardiac enlargement. If you don't fix this, then what will happen is it will lead to heart failure, because your heart is going to become unable to meet the metabolic demands of the body. However, what I really want you to realize is the most common complication following an acute MI is dysrhythmias, okay? So that's why it's so important that you're able to recognize those dysrhythmias, and you need to go back over the treatments for those dysrhythmias, because as someone who's having an acute MI, typically you will have to treat them for dysrhythmias also,